morning, everybody. My name is Mike Postow, and I'm a medical oncologist at Memorial Sloan Kettering Cancer Center. Welcome to our program this morning. We hope everyone's feeling well, and it's nice to see some warmer weather coming, and we know that it's been a challenging spring for many people in many ways. But on behalf of the melanoma service at Sloan Kettering Cancer Center, we wanted to thank AIM at Melanoma for the opportunity to discuss today with our patients and their caregivers some really important issues as it pertains to the treatment of melanoma, what we're working on at Sloan Kettering, and how we're trying to push the field forward for patients and their caregivers in this era which we've come through, which has been unlike any other in our lives prior to this time. So with this program, we will go through a number of different speakers. Each speaker represents a different area of melanoma. We have surgeons, radiation oncologists, a behavioral psychologist, and medical oncologist to talk about different issues as it may pertain to melanoma. And as we go through, the idea would be to open up a dialogue on these important topics as it may pertain to melanoma treatment. And we hope to continue this dialogue thereafter with our program so that you can feel connected to the Sloan Kettering program and to us as individuals. And with that, I would like to share a few thoughts before we get started. And one of the thoughts that I wanted to bring up is that we're really grateful for these patient organizations such as AIM to allow us to connect with patients and to advocate for patients in really meaningful ways. And when we think about these organizations, it's really to the credit of various individuals who have really championed the cause of patients in the advocacy in the melanoma field. And one of the people who has really been a leader in this area, her name is Valerie Guild, and unfortunately we lost her recently. And Valerie founded AIM. Samantha is the current president, so Valerie is her mother. And it is a tremendous loss for the melanoma field. I knew Val personally, and she was really, really helpful for my own career in terms of bringing me out and helping develop my own interest and pushing the field forward. And we're entirely grateful for all of the efforts that she's made as a field and for our patients. And Jedd Wolchok and Allison Betof additionally wanted to comment a little bit about Val and what she did for all of us. And I'll start with Jedd's comments, but a true loss for the melanoma field, and we're entirely grateful. And it's a wonder to be a part of this program today because I know she would love to see what we have to talk about and advocate for today. So with that, I'll turn it over to Jedd for a few brief comments as well.
Thank you, Mike, and thank you to the AIM at Melanoma Foundation for participating in this important event. As Mike said, we unfortunately lost the founder of AIM at Melanoma, Val Guild, and I, like many other people, felt very close to her. I think it's an overused phrase when someone talks about another individual being the heart and soul of a field, but for the melanoma community, I think many of us believe that Val really was the heart and soul of this and actually breathed life into a community of investigators to draw us together, to bring out the best in us, and to really shake up the status quo, both in industry and in government. Of course, you know, Val's signature achievement was the creation of AIM at Melanoma, and it continues to deliver on that. But she was responsible for bringing the Department of Defense funding specifically to melanoma research. She was responsible for an international melanoma working group, for a multi-site biobank, and most importantly, for bringing out the best in all of us and keeping us on our toes, making sure that we kept the patient interest first and foremost in everyone's mind. We're very grateful to her for all that she did. We're very grateful for Samantha for taking over the reins of AIM at Melanoma. And from my own personal standpoint, I will miss seeing Val at every melanoma conference, but I look forward to seeing more of Sam, and for Sam also as the chief advocate for the ECOG Akron Melanoma Cooperative Group. So I'm very, very happy to be part of the MSK contingent that is hosting this event today, and I'll turn it over now to my colleague, Dr. Allison Betof-Warner.
I just wanted to highlight one more of Val's incredible accomplishments through her work at AIM at Melanoma. One of the more challenging things in the modern era is to bring scientists and doctors together. And Val, once a year, has managed to pull together female melanoma doctors from around the country and put us in a room for a weekend and really develop ideas and talent and thoughts about the next steps in melanoma, as well as professional development. And she's been instrumental in so many of our careers. Thrilled to see Sam taking over the lead of this, but Val will be missed incredibly. I'll send it back to Mike.
Thank you, Allison and Jedd, and I think we're very excited for Sam's leadership and really looking forward to continuing such an important line of work, and we're very much appreciative. It's a huge honor, again, to have this program today. So before we get started, I did want to have Sam describe a little bit about some logistics in terms of how the program will work. And then I think we'll get started after that with our first speaker, and each of the speakers will introduce themselves a little bit about the kind of work that they do and a little bit about them as a person, so that our patients feel that they get to know us a little bit more beyond the medical side of things. But with that, I'll turn it over to Sam for a few other logistics.
Thank you. Well, so first I have to say I'm incredibly moved by what all three of you have said. You know, it's been difficult for all of us at AIM, not just myself. And so thank you. I really appreciate that. What you've shared does mean a lot. And I look forward to working with all of you moving forward and everybody in the melanoma community. I've been involved with this foundation now for 12 years, and I have every intention of continuing my mother's vision and doing more to end melanoma. So thank you. Some of the logistics I want to get going. Thank you everybody for coming. I know for some of us, especially those of us on the West Coast, it's very early in the morning. So thank you for joining us. A couple of quick notes. At the bottom of your screen, there's a chat feature. So if you guys want to talk among yourselves, you can reach out to panelists. You can share what you're thinking to the other attendees. Please feel free to reach out to people. Normally, in the past, we've done these in person. We're not able to do that. We typically like to do them in person as well, so that people can also meet each other and meet other individuals who are in similar situations. So until we can come back to doing these also in person, please reach out. If people don't respond, don't take it personally. I know a lot of people are going to be, listening and watching, but we are also recording this event, and we will be sharing this to everyone after this event. There's also a Q&A at the bottom. We encourage you to ask questions of the panelists. Hopefully we can get to all of your questions. We're also live streaming this event via Facebook, so please feel free to leave your question there as well. We're going to be watching that and bringing those questions to the panelists. If we don't get to your question, and we are going to try to get to all of them, please don't forget to reach out to your healthcare provider after the event. AIM at Melanoma also has a physician assistant you can reach out to, and Melissa will do her best to answer your questions. So without any further delay, thank you everyone, and let's get going.
Thank you very much, Sam. So with that, we'll transition to our first speaker, who's Edmund Bartlett, goes by Ned Bartlett, who's one of our melanoma surgeons at Sloan Kettering. And for many of us with melanoma or dealing with melanoma, it often deals with going to a dermatologist, having a mole looked at and biopsied, and then finding out about a diagnosis of melanoma in that respect. And I'd like Ned to talk a little bit about kind of what it is that he deals with when he sees patients with new diagnoses of melanoma, and how he approaches them from a surgical consideration standpoint, and then kind of specifically also thinking about, what are the ways that we should think about a melanoma diagnosis? What are the certain types of risks that we might have with potential for reoccurrences? How should patients think about this? What are we doing to kind of think about things from a surgical perspective? And so with that, I'll turn it over to you, Ned, to thank you very much for joining.
That's great, thank you. And welcome everyone, and thanks for joining us on what is a beautiful Saturday morning here in New York to learn a little more about melanoma. My name is Ned Bartlett, and I'm one of the melanoma surgeons here at Memorial, as Mike said. I think the one of the scariest times for patients with cancer is in that first few weeks after the diagnosis is made, but until you have a treatment plan set. And oftentimes in melanoma, that is between the time when your dermatologist calls you with the new diagnosis and when you come in and talk to one of us as a surgeon, which is usually where many patients first talk about their treatment of melanoma. So I will talk just briefly, I guess, on the nuts and bolts of surgery, because I think many of you, as your first step, have probably already been through that and experienced that. But in general, most patients with melanoma present with one spot on the skin that you can see and nothing else. And our job as clinicians is to examine you and make sure we don't think there are any other spots. And then to treat you, most patients, with surgery alone to remove the spot and the surrounding skin with the hope that that's the only place where the melanoma is. Unfortunately, that's not always the case. And in some cases, the melanoma has spread beyond the spots that we can see. And in that case, we worry about the melanoma coming back again in the future. And so I want to spend most of my time talking about what we think, what we need to know about our risks of recurrence in melanoma and what the things that we think about as clinicians after your initial surgery. But first, I think I'd like to start by defining what exactly we mean when we say recurrence. I find actually that there's a substantial amount of confusion around that point with many of my patients. And then maybe I'll discuss a little bit about the factors we use to predict which melanomas are more or less likely to recur. And then finally, I'll end with maybe a little bit about what we anticipate is the future of staging and predicting the risk of recurrence. So to start with, what does it mean when we say a melanoma has recurred? So for those of us that think about this all day and spend our days with cancer, I think many of us take this concept for granted, but often patients coming in for the first time, I think this is a real source of confusion. When we say a cancer has recurred, we specifically mean that the cancer that we thought was completely treated and was gone was not in fact gone. And the way we explain this is that melanomas have the ability to spread outside of that primary spot on your skin. And in most patients, when we remove that spot and the surrounding skin, we remove all the cells that are capable of growing back. But in some cases, cells have escaped beyond that tissue that we removed. And in those cases, the cells can be hiding in the nearby skin. They could have invaded into lymphatic channels, or they may have invaded into the bloodstream and be circulating around in the blood. But because there's individual cells, we have no ability at this time to detect them. And over some period of time, they have the ability to land somewhere and grow. And eventually they can grow to a point where we can see them. And when we see them, we call that a recurrence. So recurrence, I think, can be confused, particularly in melanoma, with a second new melanoma. But we think about these very differently. Melanomas, most of them come from sun exposure. And so we see a patient who's had one melanoma is at increased risk of having another melanoma in the future. You can imagine that the sun you got as a 20-year-old was the same sun on your left arm where the melanoma was as it is on your right arm, and it's the same skin, and so you were at increased risk for another melanoma. However, we think of a second new melanoma very differently from recurrence, because the second new melanoma's risk is completely independent of the fact that you've had your first melanoma. So the other scenario that I think is commonly confused when we talk about recurrence is that when melanoma comes back, it doesn't always come back exactly in the same spot. It certainly can come back right in the area where your original tumor was removed, but it can also come back in the nearby skin. It can come back in the lymph nodes. And as it turns out, in the case of melanoma, it can come back almost anywhere. And I think there's a lot of confusion that arises when it spreads to someplace like the lung or the bones. We see patients will come in describing this as they have had a lung cancer or a brain cancer. And while it's certainly possible that you might have two types of cancers, when we talk about melanoma spreading, what we specifically mean is that those cells from your original melanoma in the skin have actually escaped and landed in the lung, for example, and have started to grow there. So a melanoma metastasis is something that's quite different from a new lung cancer because it arose from your original melanoma. So hopefully now, if we're all on the same page about what we mean when we talk about melanoma recurrence, why do we worry about predicting the risk of recurrence? It seems like an obvious question, and every patient wants to know what's the chance of it coming back now that it's been completely removed. But in fact, the reason we as clinicians really care most about that is because we have something to do about it, but we don't have a perfect treatment. If we had a perfect treatment, a treatment with no side effects that would get rid of recurrence, we would give that to everyone. We wouldn't care if it had a 100% chance of coming back or if it had a 1% chance of coming back. And likewise, if we had a treatment or if we had no treatment, I should say, we wouldn't have any ability to intervene. And so there wouldn't be a lot of value in telling you that there was a 10% chance of it coming back versus a 20% chance. As it stands, we've currently developed some quite good treatments that are remarkably more effective than they ever were before. And Dr. Betof, I think, will talk to you a little bit about those. But unfortunately, they have side effects. And so we want to maximize our ability to give those treatments to patients who are more likely to benefit from them than to be hurt by them. And as it turns out, over many, many years of removing melanomas and then following patients in the clinic to see what happens, the field of melanoma has developed a very good sense of certain factors that increase the chance of melanoma coming back in the future. Many of you have seen the biopsy pathology report for melanoma, and you often see this long list of factors that can contribute to the risk in some ways. There are things like thickness, ulceration, mitotic rate, regression. It goes on and can be a little overwhelming when you first see it. But many of them really only have pretty minor significance or are only significant in a select circumstance. And the most important risk factors have been incorporated into our staging system. Those factors, for those of you interested, thickness is the primary one, particularly in early melanomas that we worry about. Ulceration, satellites, which are a rare finding, but can be a local spread of the melanoma within the skin, and then the status of your lymph nodes. But ultimately, what staging is it's a relatively crude way of grouping patients into large groups that have a similar risk of recurrence. And the staging that many people are familiar with across cancers are stages that range from 1 to 4. In the case of melanoma, stage 1 is early melanoma that has a low risk of coming back. And stage 4 is melanoma that has spread distantly. And generally in those patients, surgery alone is not the treatment we recommend. So because staging was designed as this a way to group patients into similar categories of risk, we have increasingly become more sophisticated at better predicting risk, and the staging system has increasingly become more complicated as a result. Right now, instead of those 4 stages, there are sort of technically 13 stages in melanoma. There's 1A, 1B, 2A, 2B, 2C, and so on. Every stage now has substages. And the clear trend is towards becoming more and more refined with our ability to predict the risk of your melanoma coming back. And in fact, probably the best way to do this is using statistical models. And if I were forced to predict the future to you all now, I would tell you that in my career, I think staging as a system is probably going to be replaced with an app that you can plug in some information on your cell phone and your pathology report details, and it will spit out your risk of recurrence. And in fact, we actually have these apps now. I have one on my cell phone called MelCalc, which is a relatively older app that can predict the risk of these melanomas. But we haven't, as a group and as a field, exactly refined how we are going to use these numbers to guide clinical practice at every step of the way. So just briefly, and I think it will overlap a little bit with Dr. Warner's, I would tell you that one scenario where we really see this as an important ability to sort of supplement our care, where the predictions make a big difference to individual patients, is in stage 3 melanoma. So stage 3 melanoma are patients where melanoma typically has spread to the nearby lymph nodes. And after surgery to remove all of the visible melanoma, patients are then eligible for something called adjuvant treatment, which is treatment to reduce the risk of the melanoma coming back. But just because you're eligible, by no means should every patient with stage 3 melanoma be treated. And in fact, that would be a huge oversimplification, and we would be hurting a number of patients if we were to do that. So instead, if we can tell you that not just your stage 3, but we can give you a precise risk estimate, we could say, for example, you have, based on your melanoma, you have a 30% chance that it's going to come back over the next 10 years. And for some patients, that 30% is a terrifying number, and they want to do absolutely everything they can to avoid the chance of that coming back. But as it turns out, we have probably just as many patients who see that number and see 70% chance that they're completely cured, that this melanoma is not going to come back, and they don't need to do anything further. And those folks are happy to stay as far away from us as possible. And I think with that information, that's a completely reasonable decision to make on an individual basis. And I would actually argue that I think when we're talking about personalized medicine, when you hear on the news or on advertisements the sort of latest new technology, the new genetic sequencing that is going to personalize your care, it's a great buzzword, but probably the most impactful individualized treatments are in things like this, where we can individualize your risk prediction and allow you to make a decision for yourself at what risk the treatment makes sense or at what risk it doesn't make sense. And these models that we are developing, and there are new ones much better than the one I have on my phone that are probably going to be out in the next few years, that I think will continue to help guide us more and more accurately in these discussions. And then I guess finally, before I turn over to Dr. Betof, I just want to get one more comment on follow-up, particularly given the ongoing pandemic and the very real concern that patients have about limiting social interactions, including doctor's visits. So our follow-up in melanoma, typically the recommendations are loosely based on the probability of a recurrence. So the higher chance of melanoma coming back, the more frequently we recommend that you have follow-up. The broad concept here is that with each individual follow-up visit, there's a small percentage of people that will have something detected. In melanoma, as opposed to in other cancers, we have a pretty good sense of how these recurrences are detected. About a third of recurrences are found by patients themselves. You feel a lump in the shower, your partner or spouse notices something they're a little worried about, and that prompts the doctor's visit. About a third of recurrences are found by the doctors during the clinical follow-up, and then about a third are found by our scans. In many cancers, scans alone find the vast majority of recurrences, and so in that setting, telehealth and looking at a scan from afar and then talking to you on the phone is certainly 100% reasonable. In the setting of melanoma, I am a little concerned about only seeing patients remotely via telehealth, and we certainly are open to these visits, and we're having them. The majority of my patient visits are telehealth these days. But I think going forward in melanoma, it will be interesting to see how we incorporate this. And I do worry that the physical exam does play a real role, at least in these follow-up visits, to identify some of these recurrences. And so it's something we're continuing to work on, but and we'll work with individual patients. I don't want to scare anyone and tell you that if you missed your doctor's appointment or delayed it a month, I certainly don't think that's something you need to worry about. But in the long run, we as a field are sort of grappling with these discussions now in this new environment. So thanks very much, Mike. I don't know if there's any other topics I should cover now, or if we wait till the Q&A.
Yeah, I think that's great, Ned. Thank you very much. What we'll do is transition to Dr. Betof Warner now, and then I think there will be some time for discussion in the Q&A at the end to come back to some of these really important points that you brought up. So thank you for sharing that. And I think people will have other questions as it may pertain to other surgical questions even as well during the Q&A portion. So I think that's a great setup for our next discussion here, which is about now that you've had surgery for melanoma and we're trying to decide about risk of recurrence, Dr. Betof Warner is going to talk a little bit about what should be some of the considerations as we think about whether treatment in that setting of resected melanoma, whether that's right for you, mostly from a general perspective, and how we should think about that, how we should engage with our physicians, and perhaps also what we're doing at Sloan Kettering to try to understand the patient experience more and offer something different in that type of particular setting. So with that, I'll turn it over to you, Allison.
Great, thanks. My name is Allison Betof Warner. Thank you all for being a part of this today and for the opportunity to talk to you a little bit about the next steps after surgery. So Dr. Bartlett did an incredible job setting up our discussion of why do we think about therapy after surgery. You know, many patients come to me and they say, aren't I cured, right? Didn't the surgeon do a good job and take out all of this melanoma? And the answer is, there is a very good chance in many situations that that surgeon cured you of your melanoma. But as Dr. Bartlett mentioned, there are many situations in which there is some risk of your melanoma coming back. And we need to really think about the risk versus the benefit of treatments that can help prevent that recurrence, or at least in some situations, delay that recurrence. So Dr. Bartlett talked about how we stratify risk and in terms of staging, and that will frame some of our discussion for medications that we can think about after surgery. So I'm a medical oncologist. I think about medicines that go throughout the body. So one thing that we know is that melanoma may recur locally in the skin where it was in the first place. It may recur in the lymph node, particularly in that first draining lymph node. But melanoma also can recur distantly in an organ or in another place. And so we want a medicine that goes everywhere through the body to help minimize that risk. And there are some older medicines that some of you, if you were treated a few years back, may have heard of, things like interferon or ipilimumab, that we don't use quite as frequently anymore. So I want to focus on sort of two types of medication that we use now. So the first is immunotherapy, and anyone, regardless of what type of melanoma they have could think about immunotherapy. And then I'm going to talk a little bit about targeted therapy at the end here. But immunotherapy works by helping boost your own immune system to recognize and treat the cancer. And we really think about immunotherapy after surgery for patients who have had a positive lymph node or stage 3 disease, right? And particularly patients who have more than one lymph node involved, or a lot of melanoma in the lymph node, or a particularly deep melanoma primary tumor, as well as some melanoma in the lymph node. And the reason for that is, as Dr. Bartlett said, we're thinking about the risk of your melanoma coming back, weighing that against the real risk that you could have a side effect with these medications. And that's where these prediction models come in and become very important to us when we think about how important is it for me to get this medication and reduce my risk of recurrence. What is my risk that I have a potentially real side effect that could be long lasting? So just a few words about immunotherapy. Many patients come and they say, this sounds great. It's using my own immune system. It must be natural. It must be safe. It is all of those things. And it is a medicine and an approach that has revolutionized the way we treat melanoma. That being said, it is not without side effects. So the main regimens we use for after surgery, the adjuvant setting, are either a 4-week regimen or a 6-week regimen. So 1 infusion every 4 or 6 weeks now, which is a new addition to our melanoma arsenal. And you get treated like that for a year. With every 3 months, we're doing scans to look for and make sure that there's no evidence of your melanoma coming back. Side effects from this happen when the immune system gets overexcited and often are very, very tolerable, and things like rashes and laboratory abnormalities that we treat with steroids. Other types of side effects can happen and can require more intervention, and we can talk a little about that later if that's of interest. But in general, right, these are very, very well tolerated medicines, and most of our patients that are on adjuvant therapy are living their normal lives, traveling when we're not in the middle of a global pandemic, and going to work and doing all the things that they normally do. I want to say briefly, many patients come to us and say, I had a positive lymph node and therefore I must have, adjuvant therapy, or someone told me I must have adjuvant therapy. One important distinction that we have yet to make in our field, we know that adjuvant therapy can help decrease the chance of your melanoma coming back and can help patients live longer over patients who did not receive any therapy after surgery. What we don't know is if you were treated, right, if your melanoma came back and then you got treatment, is that therapy just as effective? And the answer is we don't know yet. And so there really isn't a situation in which someone can say, you must receive adjuvant therapy, because we have not yet proven as a field that for sure will help patients live longer than if we treated you if your melanoma should come back. And that's where we really think about this, balance of risk and benefit. So for patients who have stage 3 melanoma, they are eligible for treatment with adjuvant therapy. And the patients that we generally really tend to treat are patients who have higher risk of stage 3C, stage 3D. Stage 3B, we certainly will treat. It's more of a conversation. But I have many patients who have stage 3A disease, meaning they had just a little bit of melanoma and just a tiny bit of melanoma in their lymph node, for whom really the risk of the treatment really outweighs in many situations the benefit. And so those are important conversations to have with your physician and with these sort of risk prediction models. If you have a certain type of melanoma that has a mutation in a gene called BRAF, B-R-A-F, which many of you have heard of, you may be eligible for adjuvant therapy with a combination of medicines that target that mutation. And this is where this idea of personalized medicine comes in. We're looking for a specific mutation in your melanoma. And if you have that melanoma, we have medicines that can come in and basically turn that mutation back off. Those medicines are, one of the advantages is that they're oral, right? They can be taken at home, at your house every day. Right? They're taken for a year, similar to the immune therapy. But many patients like this approach because it is an oral-based medication. And you're really coming to the doctor to check on side effects and to get your scans and to review your scans. Some of the downsides to that oral regimen, first of all, if you don't have that mutation, as I say to my patients, I can give you lots of side effects and no benefit, right? So you must have that BRAF mutation to be eligible for that medication. But they do have side effects. And some of the more common ones are fevers, which can be quite bothersome to patients, rashes and elevations in some of your liver numbers that do require monitoring. And so sometimes we really have to tweak what dose of that medication is or the schedule that you're on with that medication. So the thoughts here are similar with who should get treatment, right, as they are with immunotherapy. The higher the risk, the higher the likelihood that we're going to recommend adjuvant therapy. But again, we still don't know if treating you now versus treating you later is a better approach. And so one of the things that we are currently doing at Memorial is trying to understand how patients make that decision, because that's a really hard choice. You know, I have a patient sitting in front of me who says, well, I certainly don't want my melanoma to come back, but I really don't want any of those side effects that you talked about either. That doesn't sound very pleasant, right? And how do I actually make that decision? And a large number of our patients say, well, if I was your mom or I was your daughter or I was your X, Y, or Z, what would you do, doc? But we're really trying to understand how patients make that decision. And so we have an ongoing study with Dr. Hay, trying to understand the factors that patients weigh when they make that decision, and then looking down the road at how happy or not happy they are with the decision that they made. And we hope that in the next couple of years, we really will have more information to help advise our patients. And with that, I think I will say one more thing. I apologize that patients with stage 2 disease are sometimes hearing now that they may be eligible for clinical trials and for adjuvant therapy. And we do, in fact, have a clinical trial ongoing to reduce the risk of recurrence in patients with stage 2 disease using immunotherapy. But we do not yet know whether that is a beneficial approach, and that's something that's worth talking to your physician about. And with that, I will turn it back to Dr. Postow.
Thank you very much, Allison. I think that was great. And I know we'll be hearing from you more a little bit after the break on some other topics. And I think this is such a nuanced area that there will be a lot of Q&A time to talk about some of this, and especially even about some other types of melanomas, non-skin melanomas. Many people want to know about mucosal melanomas and melanomas that show up in places that may be a little bit more atypical. So we'll talk about that during the Q&A as well. With that, before we will have a little bit of break, but we have one more talk before a break, and that is from our radiation oncologist, whose name is Dr. Christopher Barker. And I think one of the special things that I feel very grateful for being at a place like Sloan Kettering, but this is really something that exists at many big academic institutions around the country, is that we have really good specific expertise in melanoma in whatever type of treatment modality might be most appropriate for patients. And Chris is a great asset for our group in that he really focuses on melanoma and other skin cancers. And so we get really deep expertise in when is radiation treatment appropriate for melanoma? What do patients with melanoma need from a radiotherapy standpoint? And it's a delight to be able to introduce him today to share his thoughts on a few of those concepts. So thank you very much, Chris, for being here.
Thanks so much, Mike. That was very nice. Yes, my name's Chris Barker. I'm a radiation oncologist at Memorial Sloan Kettering, and I'm a specialist in the treatment of cancers of the skin and of the eye. And so melanomas happen in both of those areas. And so, you know, I have a bit of experience and and knowledge about, the use of radiation treatment for melanoma. So in addition to being a radiation oncologist, I'm a father of 3 and a dog owner. And so I'm going to apologize in advance for any screaming children you hear in the background or dogs barking. But that's just the way of life living at home now in the pandemic. When talking about radiation therapy for melanoma, I think, it's important to get some historical context. Because, a lot of patients who have been undergoing treatment of melanoma for a while, come to see a radiation oncologist for the first time. And, one of their questions is, well, why have we not talked about radiation therapy for my melanoma before? And part of the reason for that is that, there's a few select situations where radiation treatments may be helpful. But, for many patients with melanoma, radiation treatments, will never really be something that's that helpful to them. So they never end up, seeing or needing to see a radiation oncologist. But, for the patients that are meeting a radiation oncologist for the first time, a lot of questions they ask are on the lines of, is this a new treatment? Is this radiation stuff that I've never heard of before? Is this something you're just starting to do? And an interesting point is that, radiation is a treatment that's been given to cancer patients for probably over 100 years. It was only a few years after ionizing radiation was discovered in the late 1800s that diverse patients began receiving treatments with radiation for, their cancers. And this is true for melanoma as well. And, interestingly, in the first few decades, in the early 1900s, there were doctors that started to form an opinion about, does radiation actually help in melanoma? Is it not helpful? And, some very early research, was reported and suggested that, radiation treatments didn't help that often. And I find it interesting that, now 100 years later, there is still some of the sentiment, in the melanoma community that radiation treatments don't help in melanoma. And so, you may hear this or read of this, but one of the things I like so much about being a doctor that works in the field of melanoma with melanoma patients is how much research we're doing. And over the years, over the last 100 years, how much research has been done to really show us, when and how, these various treatments, new treatments, old treatments, can be helpful to our patients. And so that's one of the things I'd like to highlight this morning is just how research has made such a big impact on our understanding of when and how and where, radiation treatments can be helpful for people with melanoma. In general, I would say that, radiation treatments are an ally, to the other major forms of treatment for melanoma, those being surgery and medical therapy, drug therapy. In general, when someone has a primary melanoma tumor, it's removed with surgery. We don't usually give radiation treatment for those. And I think that's for 2 reasons. One is that, as you've heard, if it's potentially completely removed, then, many people are cured with that, simple surgical procedure. The other thing is that when we remove a melanoma with surgery, we're able to learn more about it, perform some of these analyses, which, Dr. Bartlett, Dr. Betof were mentioning. And, the more we can learn about, a patient's cancer, the better we can be, the smarter we can be in terms of the approach to it as far as treatment. Now, there are some situations where removing a melanoma tumor surgically is complicated. And I think probably one of the best examples of that is a very unique type of melanoma called uveal melanoma. This is actually not a melanoma which starts on the skin. It's actually a melanoma which begins on the inside of the eye. And many years ago, doctors recognized that to surgically remove a melanoma which begins on the inside of the eye would require removal of the eye. And through a lot of work of some very talented doctors and researchers, a technique of actually giving radiation treatment for tumors, melanoma tumors that begin on the inside of the eye was developed. And this ultimately was subject to very well done research studies which proved that the chances of being cured of that type of melanoma are the same, whether or not you have your primary tumor removed with surgery or whether you have radiation treatments. But I think it's a good example of a unique situation where radiation treatments actually are very helpful, and sort of, treating the cancer and, helping to avoid, complications that could happen from, another treatment like, surgery. So, a question that is often asked of me when I meet patients for the first time is, what is this radiation stuff? So generally speaking, cancer radiation therapy involves the delivery of very high energy ionizing radiation particles to the part of the body where the cancer cells are. And there's basically two ways that this can be done. The first way, the most common way, is something called external beam type radiation. It's also known as teletherapy. And the other type of radiation treatments which can be used are something called brachytherapy or implanted radiation. So with respect to the more common type of radiation, the external beam type, you can think of this type of radiation kind of like the light that comes out of a flashlight. You turn a flashlight on, there's a beam of light that comes out from it. You can point that beam of light wherever in the room you want it to go. And in a similar way, radiation doctors, they have machines that produce beams of radiation, and our job is to aim that beam of radiation where in the body we think there could be cancer cells that need to be treated. Now the difference is that light, the kind of light that comes out of a flashlight, is a low energy radiation particle that can't get through the skin. The radiation therapy we use to treat cancer patients is high energy. It's so high energy that it can pass right through the skin and right through the body. And that's why we have to aim it so carefully so that we get to the areas that need the radiation and nowhere else. And there's lots of different types of radiation particles that radiation doctors can use to do this. So just like the medical oncologists have different types of medicines for the treatment of melanoma, radiation doctors have different types of radiation. So for example, there are types of radiation machines that produce very, very superficial radiation. It penetrates just a few millimeters under the skin, and that's basically it. On the other hand, there's other types of machines that produce radiation that penetrates much deeper in the body. It can get to the inside of the body, like the lungs or the liver, and that's a different type of radiation machine. There's different particles we use. Sometimes they're photons, that's P-H-O-T-O-N-S. Sometimes we use a type of particle that's different. It's a proton, P-R-O-T-O-N-S. Sometimes we use electrons. And so, there's different types of machines and particles that are used to deliver these various types of radiation therapy, which are all dictated by the situation. Exactly, what are we trying to accomplish with the radiation? Where are we trying to give it? Now, as I mentioned, it's really important that when radiation treatments are given, they're given very precisely, with millimeter accuracy, just to the area that needs the radiation. And so before radiation treatments can begin, we have to plan them out very carefully. Sometimes patients come to meet me for the first time, and when they come in, they say, okay, are we doing the treatment today? And I, say, unfortunately, we have to plan this out very carefully. And it's a process which we call a simulation. So what we do is we basically simulate the treatment happening before it actually does, just so that we can be sure the radiation's going right where it needs to. So during the simulation, what we'll often do is have the patient get into the position they'll be in for treatment, which is usually lying down. And then we'll usually do a scan in that position, either a CAT scan or an MRI or something like that. And then we'll also often create a special device, a cradle, a mold, something that helps keep the patient in that same position each day that they come in for their treatment. We'll do a CAT scan of that area, an MRI, so that we can see exactly where we want the radiation to go and what we want to avoid. And with that scan, we go through the process of planning this. And we often work with other specialists like medical physicists and other members of our team. And that way, when the patient comes back for their first treatment a few days later, we go through the same process which we simulated, And then we can actually give the first treatment, and we know that the treatment's doing exactly what we want it to, having simulated it and planned it very carefully. So this all pertains to that external beam type radiation. Now, the other type of radiation, which I mentioned to you, is the brachytherapy. Now, this is a little different because with brachytherapy, what we're doing is we're actually putting the radiation source very close to or even inside the area of the body where we want the radiation to go. This is done a lot less often in the treatment of melanoma, but I mentioned to you that, for example, treatment of uveal melanoma, that melanoma which happens inside the eye, we actually use brachytherapy. We use a small device. It looks like kind of a thick contact lens, and we put that, on the surface of the eye, and it emanates radiation that can get rid of the cancer cells that make up that tumor inside the eye. So it is used for melanoma in certain situations. So, other examples of rare situations when radiation can be helpful include a very early type of pre-melanoma, something called lentigo maligna. This is a very superficial type of skin melanoma, which often happens in older people and over very large areas of skin on the head, the neck, the face. And sometimes, we consider whether surgery would be a good idea in that situation, because if it's over a very large area, then a very large area of skin would have to be removed. And research over the years, primarily out of Europe, has shown that, very superficial forms of radiation treatment can be helpful in this situation. Now, it's rare because in most instances, these are not so big that surgery can't be done safely and effectively. But there are a few times where we think that can be useful. Another situation where radiation treatments sometimes are used is in patients with stage 3 melanoma. As Dr. Bartlett and Dr. Betof mentioned, that's when the melanoma cells travel to the nearby lymph nodes. And usually in that situation, a surgery is done to remove the lymph nodes. And every once in a while, after that surgery is done, we look at the patient's situation, we look at the amount of melanoma which is in the lymph nodes, and we think, is there a chance this could come back in that same lymph node area? Even though a very good surgery was done, even though we think we've removed all the melanoma cells from that area, there are some patients who are still at risk for the melanoma coming back in that same spot, the lymph node area where the surgery was done. And in that situation, sometimes we'll consider giving radiation treatments, external radiation treatments to that area to try and prevent it from coming back, from in that same area. This is actually a form of adjuvant radiation. You heard Dr. Betof mention adjuvant drug or systemic therapy for melanoma. Well, there are situations where we consider actually adjuvant radiation as well. There can also be situations where the melanoma has metastasized, traveled into the body, say into a bone, into the lung, liver, brain, and considering surgical removal of that, would be challenging. And so radiation treatment sometimes is considered in those situations, often to shrink tumors and to alleviate symptoms that they can cause in those areas. So what are some of the new ways that we're thinking about using radiation for melanoma these days? Well, one is for some very specific subtypes of melanoma. We recently participated in a big research study that's going on around the world, looking at a special type of melanoma called neurotropic melanoma. This is a melanoma that likes to grow around the nerves in the skin. And this research study was done to see whether radiation treatments to that area where the neurotropic melanoma was removed will help prevent it from coming back, because some doctors think that the chances of it coming back are higher in that area. And so that was a very exciting research study which recently finished, and we're looking forward to the results of that. In the last few years, in collaboration with Dr. Postow, Dr. Wolchok, and colleagues in the melanoma medical oncology group at Sloan Kettering, we've become interested in the notion that radiation may actually change the response of the immune system to cancer. And so we've participated and done a few research studies looking at that. And we think it's interesting. We do think there's some ways that radiation actually may change the tumor itself, may change the way that the immune system is responding to the tumor. And so, we're doing a lot of research studies at this point, combining the immune checkpoint blocking medicines, as well as some of the injectable medicines, that activate the immune system. And, we're looking forward to some of the results of these studies to see whether radiation actually will help in these situations. We're looking at other forms of radiation. I mentioned to you photons, protons, electrons. We have a research study which just started using a particle which hasn't been used for the treatment of melanoma or really any cancers very often, and that's alpha particles. And we think those could be, a potentially powerful tool for the treatment of some types of superficial tumors. I think that I can conclude and just say that, I think over the years, there's been a lot of research done, which has kind of helped us better understand, when, where, how radiation treatments might be helpful for patients. There's a lot more research that's ongoing right now, and probably in the future, we'll have an even better understanding of this. But, it's not every patient, certainly not every patient with melanoma that will benefit from radiation treatments. And I think our job is to really kind of better understand, who, when, where, and how. So with that, I'll conclude.
Thank you very much, Chris. I think you did a great job distilling a very complicated field of radiation oncology in a very clear way, and I appreciate that. I think, again, there'll be more questions related to this during our Q&A, and I look forward to that. Although we were planning to have a little brief break at the moment, since this is a virtual forum, and really all the attendees, we can really have you take a break whenever you wish. I was encouraged that we should keep going, and I think that's great. And I'd like then to introduce our next topic, which is a question that comes up all the time in clinical practice. And I think a lot of patients want to know about this, which is, what can I do as a patient to optimize my outcomes? Are there certain things I could eat, or different kind of supplements to take? Or how should I think about types of exercise that might be helpful? So how can I as a patient really do what I need to do to try to help myself have the best outcomes? And one of the great things about our group is that Dr. Allison Betof really has an interest in this issue. She's a world-class athlete and CrossFit instructor, and has done a lot of research in the laboratory on exercise and immune therapy, and really trying to understand how these kinds of lifestyle factors may or may not in certain situations play into outcomes. So with that, I'll turn the topics back to Allison, who will share her thoughts on this particular issue. Thank you, Allison.
So thanks, welcome back. I am thrilled to talk today about one of my true passions, which is how we can think about modifiable lifestyle factors in the efficacy of therapy and the tolerability of therapy. And this is a field that is relatively young when we think about cancer. As Dr. Postow mentioned, many patients come to us and say, okay, you're talking about medicines, but what else can I do? Right? Can I eat something? Can I sleep some way? Can I stand on my head for 6 hours a day? Will that make a difference? Right? And until recently, we really didn't know. We would say many things like, you should eat what your cardiologist tells you to eat because that'll help you be healthy. Really generic statements. And there are several of us, many of us in the field, that are really focused on trying to answer some of these questions to help our other therapies work better. So I'm going to talk first about exercise. So really, this is something that we didn't really look at until the mid-'80s, despite the fact that patients have been asking for many years. But in the mid-'80s, scientists really started to say, okay, can we think about exercise? We've studied this for diabetes. We've studied it for heart disease. What about in the context of cancer? And the first reaction of that in the field was like, are you nuts? Right? You just told me I have cancer. Now you want me to exercise too. You're going to give me chemotherapy or immunotherapy. You want me to do one more thing. And so the first studies actually in this field were, can we do this, and can we do this safely? And really in sort of the mid-'80s and through the 1990s, that was where the field focused. They focused on establishing the safety of exercise for patients with cancer. And really, over and over and over again, they've demonstrated that exercise is quite safe for patients with cancer. There are a few notable exceptions in which really you should, work with a doctor and potentially an exercise physiologist. Things like bone metastases and brain metastases are particular considerations that require specialized types of exercise. But other than that, really, it's been demonstrated repeatedly that not only is exercise safe during and after treatment for cancer, but it's probably beneficial too. And what we do know is that exercise can result in improvements in both fitness as well as quality of life, things like fatigue and anxiety, and tolerability of therapy. One of my main focuses and what I work on in the lab is understanding whether or not exercise in and of itself can help other therapies work better. And in the context of breast cancer and some of our larger tumors, this really has been studied in large clinical trials now and has been shown to be effective in certain settings to help chemotherapy work better. Immunotherapy is a newer approach, as we all know, and we are really learning every day. As Dr. Postow mentioned, I am a trainer on the side, but I like to joke that I'm a mouse personal trainer because that's where I spend most of my time, is running mice on treadmills, trying to understand this. And what we do know is that exercise causes mobilization of immune cells. And what we're trying to understand in the laboratory now is how we could channel that to get the right type of immune cells to the tumor at the right time, at the right activation level. And many of us, myself included, are working hard on that to try to give you a more precise answer when you ask that question, hey doc, what else can I do? Right now, the recommendations come predominantly from the American College of Sports Medicine, who really has convened every about 10 years a roundtable discussion of the world's experts on exercise oncology, and that's what this field is called. And the first recommendations came out in 2010 and then were updated last year, and really say 150 minutes of exercise per week at a moderate intensity. So what does that really mean? So that means 30 minutes per day, 5 days a week of moderate intensity exercise. And that's something like walking quickly, right? I'm not suggesting that any of us, myself included, need to go out and run a marathon, though some of us find that fun. But 30 minutes a day, 5 days a week really is sufficient for many of these outcomes that we've talked about related to exercise in cancer. Alternatively, if you're someone like me that likes to lift heavy things or run really fast, right, then vigorous intensity exercise is something like 75 minutes a week. It's really not that much. And you can obviously combine and mix and match, but really this can be as simple as, you go to the grocery store, you park in the back of the parking lot. It might be a 5-minute walk to the front of the store, then you walk through the store. If you walk at a reasonable pace, you walk back to your car. That may actually be your exercise for the day. Anything that truly elevates your heart rate. So when we think about recommendations, that's where I start. And I tell people that we're working hard to come up with more precise recommendations, particularly for patients with melanoma, to really try to hone in on this and how we can help you help yourself. From a diet perspective, there are many groups working on this. And what we do know, particularly in the context of melanoma, is that there is this odd paradox called the obesity paradox. And what that means is essentially patients who are obese or have a body mass index over 30 actually have a higher risk of developing melanoma for reasons we don't completely understand. But for reasons that we are learning about, tend to respond better to both the targeted therapy that I mentioned earlier, as well as immune therapy. And myself and others, including a large clinical trial that's ongoing now at MD Anderson, are really trying to get in and understand the ways in which that works, and how we can use diet then to modify outcomes. So some of the key things with diet, one of the more exciting findings from the recent years has been that the microbiome, or the bugs that live in your gut normally, really do affect outcomes with immunotherapy. And this has been shown over and over again in the lab, as well as now in clinical trials. And one of the things that we know is that what you eat affects the bugs that live in your gut. And so to promote good, healthy bacteria in the gut, what we know is that eating a high fiber diet, natural good fiber, right? So fruits, vegetables, whole grains, is very, very important to promote those good gut bacteria. Now, immediately when I say that, everyone asks me, okay, well, can I just take Metamucil, right? Or can I take a fiber supplement? And the answer is, I wish I could say yes, but actually there are some data that say that that may be harmful. So here, you really need to do the hard work of eating good food, right, and getting your fiber naturally. Along the same lines, a wide variety of foods is very important to promote good gut bacteria and a wide variety of gut bacteria. So I keep mentioning gut bacteria. So then the next question everybody asks me is, okay, well, what about probiotics? Right? Isn't that good? It must be great. You're telling me that gut bacteria are good for me. And the answer is, I want a really wide variety of gut bacteria to help your immune system respond as well as possible. And a probiotic often is 1 or maybe 5 or even 10 strains of bacteria, but not that wide variety. And so instead of actually helping, probiotics potentially are even harmful in kind of pushing your microbiome or the gut bacteria towards certain bacteria and away from the diversity. So at the end of the day, I'm going to tell you what you didn't want to hear, which is, you know, the things that you can do to help yourself: eat well, exercise, right? Supplements aren't the answer here, right? And unfortunately, we all really have to do the work both in the prevention of cancer as well as its management. And I'm happy at the end to answer any additional questions about this, but I'll turn it back to Dr. Postow.
Thank you, Allison. I think that's great. And I think that it's also important to recognize, if you have additional questions about other types of approaches, things that you could do that are not part of the conventional radiation, surgery, medical drugs that the oncologists or other team members are prescribing in a medical way, we have a really great integrative medicine service at Sloan Kettering, and I know a lot of other organizations all around the country will have these kinds of groups of physicians that really know how to incorporate additional types of therapeutic modalities, acupuncture, Reiki, these types of things. And while that is not to be necessarily a substitute from all of the other conventional treatments that we have to help with melanoma, the goal is that that could often supplement the treatment and make people feel better. There's studies that show it can help with pain and relieve stress. So I do think that that is important to think about. And it is something to ask your physicians about, hey, what do you think about this? And I think there's some really great services that we at our institution can offer and that are offered everywhere. And certainly a very important topic that comes up along the trajectory of care. So with that, I wanted to talk for a few minutes about another topic, which is clinical trials and how we learn new areas of melanoma and how we're trying to push the field forward for patients with different types of melanoma in different stages. And then after this discussion, we will have some time for a Q&A session. I've been getting a lot of great questions throughout the course of this, and we plan to address as many as we can during the time that we have available. We're a little ahead of schedule, which is great, which means there'll be more time for Q&A. So that's fantastic. So with this, I wanted to introduce this concept of clinical trials. And what is a clinical trial? I think that's the first type of issue that comes up. So clinical trials have a lot to do with trying to learn something new about melanoma as a field. But importantly, clinical trials may offer an individual patient the best type of treatment that they could be getting in that particular situation. And so I think when we embark upon thinking about whether a clinical trial is right for me, both on the patient and doctor side, I think it's important that we all keep in mind that the number one priority always in thinking about whether clinical trials are right for me is that whether that trial offers the patient the absolute best treatment option for their particular situation. So although it is certainly important that we learn a lot about the field, we learn about how new drugs work in certain situations, we learn about whether a surgery is better done this way or that way, or we learn, as Dr. Barker was mentioning, whether there's a role for radiation in certain subtypes of melanoma. That's critical for us as a field so that we can take care of patients for future generations in better ways than we could have in the past. The most important thing I'll reiterate about trials is that it's really critical to understand that if your doctor is offering a trial and you're thinking about this as a patient, that you know that that trial is being offered because that's the best individual option for you as a patient. And it's important to try to make sure that you understand why the trial might be the best in that type of a particular situation. So what are some examples of when a trial might be right for you along the course of your melanoma treatment? So number one, it would be whether a trial offers a drug in a situation that a new drug might be promising, but might not yet be FDA approved. And at Sloan Kettering and many institutions around the world, participation in clinical trials allowed patients to get access to new promising treatments that were in drug development prior to their availability by FDA approval and oncologists all over the world. So at Sloan Kettering, I'll give Dr. Wolchok a lot of credit. He really led the charge for developing the first immune checkpoint blocking antibody ever approved for any cancer, and that was ipilimumab in melanoma. And also at Sloan Kettering, Paul Chapman, who has been a very experienced melanoma clinician here, he led the development of a drug called vemurafenib, and that was a drug for patients with BRAF mutant melanoma that really improved the outcomes for those patients. And so both the strategies of immune therapy and BRAF-directed treatment have been stories that really emanated from our group at Sloan Kettering, and both Dr. Wolchok and Dr. Chapman have been real world leaders in this type of an area. And I think what's important for patients to keep in mind is that by participating in those trials and signing up for those drugs when they were very, very promising before they were able to be offered by the FDA, it allowed patients to get access to special treatments that were very promising and help them live better lives and longer lives. And this was a very important type of treatment to access at that time when it wasn't otherwise available. So I would push all patients to ask their doctors, is a clinical trial right for me? What kinds of drugs are promising in clinical trials right now for my situation? And would that be an opportunity that I could accomplish with my treatment plan? In addition to the benefits of getting access to some of these drugs that might not otherwise be available, sometimes trials test existing standard of care treatment with another drug on top of it or new combinations. And I think those are also very valuable to participate in because patients would be getting these standard of care or the best that's available plus something else that either from laboratory experiences or smaller clinical studies suggest might be better than just the one drug by itself. So we're trying to see if different combinations can also improve outcomes. We're also trying to see if the combination treatments that we're giving now can be given with less side effects or in different types of ways. We're doing studies where we can try to understand how best we can image the immune system as patients undergo treatment. And as was mentioned before by Dr. Betof when we were talking about adjuvant treatment and is it right to do surgery for me after treatment for me after surgery, we're trying to understand from a patient perspective the feelings and thoughts that they have in terms of how do they make that decision. These are all kinds of important issues for trials. The other point I'll mention about benefits for trials is that for certain rare subtypes of melanoma, like mucosal melanoma, which is melanoma that arises in non-sun exposed areas, like the inside of the nose or inside of the mouth, those kinds of melanomas are less common than the traditional skin melanomas, so we don't know enough about them as a field. And we have faculty members, Alex Shrustari, who's unable to make it today, but wants to express how important it is that we care for our patients with these less common subtypes of melanoma and enroll them on trials so that we can really understand how our treatments work in those situations and how best we can appreciate the biology of those types of melanomas so that we can improve the outcomes for those subsets of patients. With that in mind, there are a couple of different issues that I think are important to consider if you're thinking about a trial. And there are different types of trials. Not every clinical trial is a treatment trial where we give different types of drugs. Some trials merely collect tumor biopsies or collect blood, and those specimens go to the laboratories where laboratory investigators are working on trying to understand melanoma from a biologic perspective. At Sloan Kettering, often we'll get patients permission to do extensive genetic profiling of melanoma tumors. And the goal there is not only, number one, to try to see if we can find a target that might offer a treatment in a certain situation, but importantly, we want to understand more about the genetics of the melanoma tumor biology so we can understand how that might weigh into risk of recurrence, how that might weigh into likelihood of benefit or not from different types of immune treatments or other targeted approaches. So there are a lot of different types of ways to participate in research beyond signing up for receiving some type of an experimental drug. With the thought about these types of trials, I wanted to reiterate that before any clinical trial gets started at our institution or all academic institutions around the country, it's really important that those trials are vetted with a very rigorous program of review. So what happens in the vetting process for the review? Number one, we want to make sure that the science of our trials is very sound. So we want to make sure that if patients are signing up for these clinical trials, they've gone through numerous scientific committee reviews to make sure that there's a good rationale for the trial. It's set up from a statistical perspective to ensure that a question is being answered, and that everything every patient does in a trial is being intended to answer an important question for the field. And we have a number of different committees that review different types of trials as they get to advance prior to opening. And one of the big assets of our service, Dr. Paul Chapman, one of the leaders of our group, is in charge of one of these scientific committees. So it really helps us understand what are the best types of trials to move forward as a melanoma program. Additionally, there is a group called the Institutional Review Board, or IRB, and that group is intended to ensure that patients are protected with all kinds of clinical research. And many patients may have reasonable concerns about experimental drugs. Why are certain treatments being prescribed to me? And I don't want to feel like a guinea pig. And why is my doctor suggesting I take this drug that we don't know a whole lot about? The Institutional Review Board, or IRB, is a group of people, nurses, doctors, researchers, and even patients that come together to try to understand the trial and ensure that the trial protects the rights of patients prior to the patients going into the trial. Every single time a patient is approached for a clinical trial participation, those protocols have all been IRB approved prior to patients being considered for enrollment. The other issue I will say about clinical trials is that there are a lot of misconceptions sometimes about clinical trials. Many people think, if I sign up for a clinical trial, am I going to be getting a sugar pill? I want to make sure I'm getting a treatment because I have melanoma and I don't want to get a sugar pill. And what I will tell you is that the concept of a sugar pill, which is something called placebo, is that in almost all clinical trials, there is no placebo. Almost all trials use the standard of care or the standard of care plus something else. It is critical to ask your doctors, if you're thinking about a clinical trial, is there a placebo in this trial? And if the answer is yes, you should really understand what the role of the placebo is in that situation. And by design, the institutional review boards and other committees that have scientifically approved these trials ensure that the use of that placebo in that type of a clinical trial is a situation where there is something called clinical equipoise, meaning that doctors really don't know if a certain treatment is better than a placebo type of a treatment. So for an example, for something like this, one could think about some type of an immune therapy approach, which we have proven to be beneficial in patients with melanoma, or that same exact immune therapy approach plus a new experimental drug. But for the way that the science needs to move forward, we would test the standard immune therapy drug plus the new immune therapy drug, or patients getting the standard immune therapy drug plus a placebo. And the reason for the placebo is to maintain the integrity of the study such that we really understand what the contribution of this additional therapy on top of the standard of care immune therapy may be. So that's one example where a placebo may be used. And it's very important to understand that most clinical trials don't have a placebo. The other topic I'll mention, in kind of closing with a few final thoughts on clinical trials, is that clinical trials unfortunately have been limited in access, meaning most patients that are getting treatment for melanoma or many other cancers don't get clinical trial therapy. And it's really important that we enroll as many patients on clinical trials as we possibly can so that we can learn as much as we can as a melanoma field and provide patients with new promising treatments that otherwise were not available. Traditionally, only about 5% or so of patients across the country that are getting treatment for melanoma enroll in clinical trials. So it's very important that we address why that's happening. And there are organizations such as AIM, other organizations that can help people try to find whether clinical trials are right for them. It's important as patients that you advocate for yourself, that you ask about clinical trials at the different institutions, ask your doctors if referral for clinical trials makes sense in that particular situation. And we need to expand the numbers of patients that are treated on trials so that we can learn more, especially about these rare subtypes of melanoma that we don't know as much about. In this post-COVID era that we're entering in, with expansion of virtual interactions, telehealth, phone call medicine, clinical trials are more nimble now than they have ever been before. One of the big barriers that we had always had to getting patients on trials is that patients had a fear of living far away from places where trials were offered, or not being able to come in for the different types of evaluations which were often needed in clinical trials, because sometimes in trials there's more EKGs, there's more blood work that's needed to be collected, there are more CAT scans, so there's a little bit more medical interventions, mostly because we need to try to understand and care for people in a bit more rigorous way in trials. But now with the post-COVID world that we're entering into, and more expansion of telehealth services, shipping experimental drugs to patients' home, my hope, and that I know that's something that we're working on at Sloan Kettering a great deal, is how do we increase access to trials, make it more that not only our portfolio as a melanoma program, but also our institution's trial portfolio and trials in general can reach more patients in a far more convenient way than has ever been able to be happening than before. And as the world has gained increasing attention on clinical trials, I know we've all been hearing about all these trials with COVID and hydroxychloroquine and all these other issues, remdesivir. I think there's an awareness now in patients and in society of the importance of trying to understand clinical trials and understanding about the pros and cons of different types of drugs, that we need to harness that enthusiasm combined with the ways that we can be more flexible and nimble with our delivery of trial care for patients. And our hope is that we can increase that number of patients that are treated on clinical trials as we're moving forward. So with that, I think there are a lot more topics that we could talk about with clinical trials, but those are the main general concepts that I wanted to impart. And with that, I think we will have some time and plenty of time to have a Q&A session, which will be really great. And I also wanted to remind everyone that we are here for your questions. This is a really great way that we've started our conversation around some of these important melanoma issues, but this is intended to really be a kickoff of ways that we as a melanoma group at Sloan Kettering hope to continue our engagement with patients as we move forward with organizations such as AIM and other patient-facing organizations, because we need to keep hearing from you as patients what's important. It's very important for our program to be able to deliver that for you, and we certainly welcome your feedback on this program and others that we continue to do as time moves forward. So with that, I will close the official program and I'll begin to take some questions, and I will try to redirect the questions as much as we can across the different speakers. So I will make sure to make it clear when those questions are coming in. I guess before I did that, I did want to just mention, so that we're aware of potentially some of the questions that might come in. Jennifer, if you would like, if it's possible, do you mind introducing yourself and explaining a little bit about the program that you run? And I think that will be helpful as we generate some more questions and discussions for this last half hour or so of the program.
Sure, absolutely. Can you hear me? Yeah, okay. Hi, everyone. I'm Dr. Jennifer Hay. I am a clinical health psychologist and behavioral scientist, and work obviously very closely with the melanoma service. I see, predominantly or exclusively all melanoma patients in my practice. And as Dr. Bartlett was saying just right at the beginning, getting diagnosed with melanoma can be quite scary. You know, and the social and psychological challenges don't stop with just diagnosis. You know, a lot of those challenges persist into, you know, making decisions about treatment, dealing with side effects, trying to maintain quality of life across the treatment trajectory, and then into survivorship and sort of getting back to life and you know, resuming all of your, you know, activities and work and family and all of that. And so a lot of the work I do really involves working with patients, you know, to look at what are the challenges that they're facing. How can we kind of, you know, populate that toolbox so that, you know, we're looking at the strengths that you have in your life and how to really capitalize on those things, and to really isolate what are the challenges, what are the emotional challenges, the, you know, family communication challenges, the social challenges, so that we can really kind of, you know, kind of whittle them down and then really directly address them. So, you know, I work with all of the melanoma doctors across dermatology, surgery, oncology, and it's really kind of just another element of how we're trying to kind of treat the whole patient, you know, and to really involve the family in that process. So that's the kind of work I do.
Thank you, Jennifer. So I want to make sure that everyone knows for this Q&A session, there are two different ways you can submit your questions. Number one is through the Q&A at the bottom of the Zoom link, and a number of questions have been coming in that way. The other way is to post a question under Facebook Live. So either one of those two ways, we will have the questions come in. And I think the first question is a kind of general question, which I will first direct to Ned and then Chris and others if you wish to comment upon this. And I think this will be good to have an informal discussion. And the first question is, how do we make decisions about a treatment plan for a patient as a melanoma multidisciplinary team? We've talked about surgery today, we talked about systemic therapy, we've talked about radiation therapy, we've talked about some of the patient feelings and subjective experiences that they're undergoing when they're deciding among all these different types of treatments. So I want to kind of first get Ned's opinion on how do we as a team make this decision, and get Chris and others to comment on this. And then Jennifer, I'd like your take too about how patients should be handling some of these feelings as they may be working with multiple different doctors, and how they can kind of get the kind of support that they need, and caregivers can have the support that they need as they try to kind of navigate a little bit of this world. So Ned, we'll start with your thoughts on that.
Sure. So as surgeons, we often are the first physician that you all will meet if you come in with a new diagnosis of melanoma. And so it is often our responsibility to then connect you to the rest of the resources that you need for your care. Many patients with melanoma may only need to see a surgeon. If you have an early melanoma and it's removed completely, often the surgeon and the dermatologist who made the diagnosis are the entire group that will be involved in your care. But for patients with higher risk melanoma or potentially other health concerns that are related, a broader team is needed. And so our job is to assess you and to then direct you to the appropriate additional team members. We as a melanoma group every Friday sit down and discuss, or now sit down via Zoom and discuss every case of a melanoma, the new patients that are seen by all services. And that we sit down with this multidisciplinary group, and it's really a nice opportunity to present each case. And for the patients that only need surgery, the discussion often is short. But for patients that, you know, if Dr. Barker thinks they might be able to add something, then we make the referrals. But it's a nice opportunity to review everything and make sure there's not something missed. And I think these multidisciplinary groups are common in many places, but they're a huge asset to care when you have a complicated disease like melanoma.
I think that's one of the one of the other things that I like about working in the field of melanoma is the multidisciplinary nature of it, working with doctors, clinicians, of all types, with all types of backgrounds and, interests. One of the other things that I think's important to think about with respect to this question is, I think our role as physicians is really to counsel patients. Once upon a time, there was a model of practicing medicine which was very paternalistic. That is, doctors just kind of said, you're going to do this, and that's the way things were done. But I mean, at least in my practice, and I think the contemporary practice of medicine is more of a shared decision making, where our job is to explain, to patients everything that we know about their situation. Whether it's statistics, facts, all the ins and the outs, everything that we know about their situation. For me, it's often discussions about radiation therapy. But, our job's not to tell patients what to do. It's more to educate them and to help them, make a decision that they're most comfortable with. And I think a lot of, the topics which have been brought up regarding, say, adjuvant therapy, there are no hard and fast, if this, then that type decisions that are made. A lot of these are discussions about risks and benefits, pros and cons. And I think, that I see is, one of the major advantages of the group of doctors that I work with in the melanoma team is that, each, I think, has the ability and, very easily can carry out those conversations in a balanced fashion. And I think that that's really an important part of the whole process of the journey through melanoma, really.
Jennifer, what are your thoughts? And then we'll also get a medical oncology opinion after that.
Okay. So, I guess just to capitalize on what the others have said is that, the working together of the team is really kind of personalized medicine in the best sense of the word, is that, no one solution is right for every patient. And so, my input on that or perspective on that is that, often patients really need some time apart from family, one-on-one, either, through telemedicine or face-to-face, hopefully we'll get back to that someday, is to really explore individuals, patient values and preferences, because that can be reflected in, a person's situation in life, where they've come from, where they're going, and that really is very individualized. And so bringing back those reflections about, well, what are my values as I pursue my treatment is really valuable to explore. The other thing that we often spend a lot of time on in counseling is trying to understand, well, what are the questions that I have from my oncologist or my surgeon as I go back and speak to them again. And some of those questions are not immediately evident to the patient, and some reflection about personal values helps to really kind of hone those questions. And sometimes we'll just spend time in a session writing out what those questions are. The patient will pull out their phone and write down what those questions are and really hone them, because there's often information that they want to get from their physician that they haven't been able to get yet. And just the third and final thing is, just some confidence that the doctors are talking to each other is often really helpful. And, sometimes I have to kind of encourage them to make sure that they are, getting that information, that their, outside specialists have been talking to their MSK doctors, and that everybody's on the same page. So really sort of acting as a personal advocate for themselves, and to really kind of just, get very clear on what their preferences and values are, is a lot of what, our work contributes to the process.
That's great. And then I wanted to ask you a kind of a follow-on question to that, is that how can caregivers support patients through this journey? Especially now we're running into a lot of challenges in different places where only the patient can come in for the in-person visit or the in-person treatment. So or even telemedicine. Sometimes it's kind of a one-on-one experience if you're on the phone, and there's some technological challenges, although we're trying to overcome those with multiple people on Zoom calls or other people in the background. Can you talk a little bit about the role of the caregiver, especially now with our current challenges, and how that person can really be supportive of a patient undergoing treatment?
You know, I think that that's a great question. And I think it breaks down into two pieces. One is, you know, how can the caregiver help the patient? But then also, how can the caregiver, you know, acknowledge and make sure that his or her needs are getting met as well? Because, you know, as we all know, being a caregiver is a challenging position, challenging situation in and of itself. You know, so in just in terms of helping the patient, is that, you know, I think that, you know, they really need to acknowledge what kind of time they need with the patient in order to help kind of, you know, make sure it's not all about just instrumental needs or, you know, picking up medications or, you know, sort of navigating family demands, but also just what kinds of things can be maintained so that you're, you know, enjoying life together, you know, and just sort of accentuating the positive even while the challenges sort of ramp up as well. You know, but that other piece of it is that, you know, caregivers need basically be capitalizing on their ways to take care of themselves. And that you know, definitely involves, you know, good diet, sleep, exercise, absolutely, having some time apart from the patient so that, you know, you've you know, are maintaining part of your life independently, so that, you know, finding the best ways to be together and the best ways to be separate can allow the caregiving demands to be, you know, a little bit moderated or put in perspective.
That's great. So I'll have an opportunity for Dr. Betof Warner, and then after her, Dr. Jedd Wolchok, to just share their thoughts on this topic of multidisciplinary involvement and some of this patient experience, particularly as it may pertain to systemic treatment delivery that we're giving in the medical oncology community.
Thanks. So, you know, the Friday afternoon meeting that Dr. Bartlett mentioned, I think is just absolutely central to the care that we deliver at Memorial. You know, many places have a tumor board, as you may hear it called, or molecular tumor board. But I think one of the really unique components to our group is that we do have Dr. Barker, who really specializes in melanoma radiation oncology, and Dr. Hay, who comes to these meetings and helps us navigate some of the psychosocial issues, as well as putting the surgeons and the medical oncologists all in the same room. We do talk about every single new patient that we see to make sure that you know, we're addressing all of those needs for our patients. Thinking about, you know, just in the last couple of weeks, we've seen several patients who on paper may have looked very similar, you know, stage 3B, stage 3B, stage 3B, but are very, very different patients with very, very different needs. And I think when we are able to put our entire group in a room or on Zoom and discuss these, we really are getting optimal care. It's one of the reasons I chose to stay at Memorial and come on faculty here at Memorial. And I think it is, it's really invaluable to the care we give our patients.
Dr. Wolchok, do you have any additional thoughts on this topic?
Yeah, it's a really important topic. And I think, you know, it's a promise that we make to all of our patients at MSK, is that if they see one of us, they see all of us. And so, you know, you automatically get multiple opinions, because whatever treatment path we outline for discussion with the patient really reflects the group opinion. And I think that's extremely important, because sometimes people will hear about, you know, one of us and only want to see that person, and that person might be away, or, you know, well, not now, obviously, but you know, that person may be on inpatient service or not available for a few weeks, and the patient appropriately may feel like they're missing out on something by not having a dedicated visit with, you know, Dr. Callahan, for example. And I think that it's important to know that everybody gets the benefit of the entire group. And that's something that it's a promise that we keep every Friday. And it's something that's been at the ethos of the melanoma team at MSK for as long as I can remember. The other point which expands on that a little bit is that, you know, the concept of additional opinions at other institutions. And I think we as a melanoma community, really, because of the efforts of AIM and Val in particular, we are all very collegial with each other, right? So we are completely happy that you're seeing some of our friends and colleagues at other institutions. And we recognize that that's important. And so we never think badly of that. We encourage it if people have suggested, you know, well-meaning friends or family members, you know, that you see colleagues at other reputable institutions. So we're all in on that. What we sometimes try to discourage is sort of like, you know, the melanoma tour of the East Coast, where someone's care gets delayed, for example, because they're lining up all these opinions. Often we, as a group of melanoma oncologists, really, again, because of the efforts of Val to make us, you know, do our best to be collaborative and communicative, we talk to each other all the time, and we can often save you the trip by reaching out to that doctor that you haven't been able to yet get an appointment with. So we're here to help you in every way. And certainly at MSK, you get an opinion that's, you know, the distilled knowledge of a large group of people who very happily congregate virtually or in person every Friday.
That's great. I think that's a really big strength of big kind of centers that have a lot of expertise with melanoma, and the melanoma field, I think, to Val's credit and many others too, it's such a close, tight-knit group of people that within minutes, many of us can discuss our case, not only internally as a melanoma group, but with external people. We're getting emails from people all over the world, sometimes with really complicated cases. So I think that's an advantage of if you can go to a place where there's a lot of melanoma expertise and people can put their heads together, because no two cases are alike. One of the other questions that's come up, and I think I'll start with you, Allison, which is trying to think about immune therapy treatments and duration of treatment. How are we weighing how long you have to be on treatment, how frequently you get treatment, and side effects? I think that's a very big question, but I wanted to get your thoughts on kind of just what we know as a field in general, and kind of what is it like to be under treatment, if you could explain that, and how are things hopefully changing in the future after COVID, and how are new care systems going to be deployed that we can take care of patients in more convenient ways closer to their homes, however that looks, not only just as an institution, but really as a melanoma field.
Great. So these are some of the absolutely key questions that we face as medical oncologists to decide not only what treatment is the right treatment, but how much treatment and for how long, and when do we stop, and what do we do after we stop. And so one of the first things I would like to say is that is also part of these sort of Friday discussions with our group. So yet again, you are not getting, you know, a patient here is not getting one physician's opinion. We really do discuss these individual cases as a group, because we are learning every day new data, new guidelines about how long patients need to be on therapy, or, you know, for example, how much therapy they need in total if they've had a side effect. I'll give some general guidelines that we tend to think about. So adjuvant therapy, those clinical trials were performed for 1 year. And so in general, if a patient has had surgery and has been cured of their melanoma by their surgery, or has no evidence of disease on their scans, we in general recommend therapy for 1 year. In the last, excuse me, just a couple of weeks, and during the COVID pandemic, we've had approval of pembrolizumab at 6-week dosing. That, just to be clear, is not a lower dose. It is simply a more extended dose. And that's something that we have really advocated for, particularly during the COVID pandemic, as it decreased the number of visits that patients had to make to their physician or to get an infusion, which is just one more exposure to the healthcare system. But we generally advocate for a total of 1 year, no matter how you divide that up into 4-week treatment or 2-week treatment or 6-week treatment, unless a patient is having side effects. Side effects sometimes do require true discontinuation of treatment. Other times we treat the side effect and then we're able to resume treatment. And that is really an individualized conversation depending on the severity of the symptoms, how easy the symptoms were to treat, and really how far we are into the course of therapy. In the metastatic setting, when someone potentially still has melanoma, these discussions are a little bit more complicated. So when we think about chemotherapy for other diseases, right, patients just get treated indefinitely, right? You start a chemotherapy regimen, you stay on it for as long as it works. If at some point it stops working, you change therapy. In melanoma, because particularly these immune therapies have been so effective, we know that there is a percentage of patients who will have a response that will persist long after, and potentially permanently, after they discontinue the drug. In essence, we say we've taught the immune system to help control the cancer. So the original clinical trials looked at keeping patients on for a total of 2 years if they had what's called a complete response, meaning all of their melanoma went away on their scans, or 1 year past that complete response. In more recent times, given the cost of these medications, the inconvenience to patients, and the risk of side effects, we've gotten very interested in, can we stop earlier than that? Right? Do patients really need a full 2 years, or do patients need 1 year past a complete response? And myself and others in our group this year really went back and analyzed all of our patients at Memorial who were treated with the PD-1 inhibitor, so pembrolizumab or nivolumab, and really looked at our patterns of discontinuation. And that sets us up for hopefully some clinical trials in the years to come to look at shorter courses of immunotherapy. But really, these decisions are made on an individual basis, depending on risk of recurrence, how many side effects one is having, and how hard those side effects are to treat. In terms of bringing that treatment closer to home or making it more convenient, I think as we as a field have gotten more comfortable both with giving these medicines and with managing the side effects of these medicines, it has been increasingly important to us to emphasize convenience of this for patients and integrating this into your regular life, that your life is not about treating your melanoma. Your melanoma is a part of continuing your life. And so, these extended dosing schedules. So it used to be that, you had to get treatment every 2 weeks, and then it became every 4 weeks. And as I mentioned, we now have an option, at least for some patients, to do every 6 weeks, as well as, our regional care network. So us and many, many other large hospitals are working on bringing clinics closer to you, where, either through telehealth or physicians located specifically at those clinics, one can be treated closer to home so they don't have to drive into Manhattan or wherever your doctor may happen to be.
Thank you, Allison. I think with such a challenging topic about duration of treatment, what happens along the treatment continuum, I think that's where our multidisciplinary discussions really come into play, not just at the new patients that we see, but when patients that we're taking care of in a longitudinal way come up with challenging side effects or treatment decisions along the continuum. Many of these patients we've known for years. That's where our discussions every week as a service come up again. And we certainly talk about patients that we've had in follow-up that are facing important decisions along their treatment trajectory, especially around discontinuation of treatment. Should we stop now? Should we keep going? Those patients are also a part of these multidisciplinary discussions. And I think when we think about these multidisciplinary discussions, one group of patients that really benefits from everyone putting their heads together on the best treatment plan are patients with mucosal melanoma. And I know we've gotten a lot of questions about mucosal melanoma. Mucosal melanoma is melanoma that shows up on the inside linings of the body. So unlike regular skin melanoma that might show up on the chest or an arm or a leg, mucosal melanoma could show up on the inside of a sinus or in the inside of the mouth, or sometimes in the anorectal area or vulvovaginal location. So with that, I wanted to just kind of make the rounds again with everybody to see, how do you view a diagnosis of mucosal melanoma? And I'll start, Ned, with you, from kind of thinking about some of the surgical issues that might be unique in this patient population in a general sense. And Chris, kind of what the role for radiation may be in these populations, and then both with Dr. Wolchok and Betof for systemic treatment understandings and considerations, and Jennifer, this group of patients certainly has a lot of unique issues that are different and may feel that it's important to think of them separately or in a different way than regular skin melanoma. So let's talk for a minute about this particular group of patients, and Ned, we'll start with you.
Sure. So the surgery for mucosal melanoma really is dramatically different than for patients with cutaneous melanoma. I think cutaneous melanoma is a skin excision. It's a superficial operation, and although there are some complications and occasional particularly challenging ones, the vast majority is a relatively straightforward procedure, and we get patients through it with very high success. Because of the locations that mucosal melanoma can develop, the surgery often is a much more invasive and a bigger deal. And also, because of the presentation of these very rare tumors, often is delayed, or they are misdiagnosed or thought to be something else. And because of that, they can present in a much more advanced fashion than the typical spot on your arm that you've been able to watch and monitor sort of very closely. And the surgical intervention then becomes a much more multidisciplinary discussion. For patients that it can be easily surgically removed, no question, that's the right approach. But for patients with these more advanced lesions, we have to discuss whether we consider doing treatment first sometimes, or if a smaller operation followed by radiation or followed by additional treatments is better in terms of quality of life, balancing sort of the risks and benefits in every sort of individual presentation.
Yeah, I mean, just to pick up on Dr. Bartlett's comments, I think over the years, mucosal melanoma is so rare compared to cutaneous melanoma. There hasn't been the large amount of research done in this area simply because there just aren't that many patients that we see that have mucosal melanoma. But over the years, I think there has been an evolution in the way that we think the best type of treatment can be done. I think initially, the surgeries that were done were very radical surgeries. Entire organs were removed where the melanoma actually originated. But I think, now looking back in more recent years, with more conservative surgery, it sort of seems like, the more radical operations may not be needed. So I think the evolution that I've seen over the last, say 10 to 20 years is a shift from, more radical surgery to less invasive surgery. And, I think there potentially radiation comes into play more often. One of the other issues with mucosal melanoma that's unique compared to cutaneous melanoma is that the melanoma cells often travel over a large area of the mucosa. And, knowing that, that's sort of why, more radical surgeries were done previously. But, it seems as though, that type of operation versus more conservative surgery, doesn't really help, much more mucosal melanoma. But, a treatment which goes, is directed towards that mucosal area can potentially help. So that's, again, where, radiation, for example, may become helpful. Now, on the other hand, these are often very sensitive areas of the body, the sinuses, the nose, the mouth, the anorectal area, the vulvar or vaginal areas. Those are sensitive areas when it comes to radiation therapy. But, there are well-known techniques to be able to give radiation safely to try and minimize, side effects. And so that, when we're considering radiation treatments, we're obviously doing it with that in mind. I will mention that, there has been an interesting evolution in terms of, medicines for melanoma in general. And it appears as though, there's perhaps even a new class of medicine which has shown some level of activity for cutaneous melanoma, but it seems like it's helpful in mucosal melanoma as well. And we have actually, just as of this week, I was in discussions with Dr. Shishtari, a member of our melanoma medical oncology team, about a new research study which we'd like to do, looking at variations in medicines and radiation treatment paradigms for patients with mucosal melanoma. In these early discussions with him, just to kind of point out something that Dr. Postow earlier mentioned about clinical trials, we've already recognized that it's going to be difficult to do these studies because there's so few patients who have mucosal melanoma that we see. So it will probably require collaboration between our institution and potentially others as well. But again, that's what Dr. Wolchok mentioned is the great thing about this melanoma community, fostered by AIM and folks like Valerie Guild, is that the collaborative nature of the institutions. So from my perspective, even as of this week, we're still trying to push the envelope, improve these treatment paradigms, by doing new studies, and it's always on our mind.
So, Jennifer, I guess I wanted to get your opinion on patient-centered feelings and issues that they may have with the diagnosis of mucosal that might be different from regular skin melanoma. What do you think patients need to know?
Yeah, I think that they sort of fall into two areas. One is just, how rare these diagnoses are and how often they are delayed. And that often generates, a lot of feelings, feelings about, prior physicians that they've seen that might have missed this, personal concerns that they might have missed this. And, that just persists into treatment, often just to kind of process these feelings and come to terms with them. And the other is that, it is such a rare melanoma that often it's hard to explain to family and friends exactly how this is a, skin cancer, because it's just not anything that, people have heard of or thought of as a melanoma or a skin cancer. And so, it becomes difficult for patients to convey that and to, get their care team and family on board. So it's just those two issues, down the pike as they go through treatment and survivorship, it's pretty similar to other melanomas, but it's really about kind of coming to terms with how did I get this, how was it missed, and what is this diagnosis? How do I explain it to others?
Okay, great. No, thank you very much, Jennifer. We're coming close to 11, and we do need to stop then. I just had one quick question just for Dr. Wolchok here. I think just thinking broadly, and then we'll close. But so briefly, Jedd, how do we think about what we've done in melanoma with immune therapies and other treatments that really has informed all of oncology? I've gotten a lot of great questions about, I've had melanoma, now I have another cancer. I've heard some of the drugs that I might be taking for melanoma being used in other types of cancers. Can you comment a little bit about that briefly and kind of what we've learned and how it might apply more broadly?
Sure, thank you, Mike. And I think it sort of reflects a little bit into the mucosal discussion as well, that one of the things we've learned about immunotherapy, specifically checkpoint blockade, is that it seems to work best in melanoma patients who have more genetic damage in their tumors, more mutations, because that simply makes the melanoma look less like a normal skin cell and more like something foreign. And that's what the immune system is sort of trained to see. And that's one of the reasons why mucosal melanomas may be less likely to respond to immunotherapy, although it's important to stress that the treatment principles remain the same. There are people with mucosal melanoma who respond to immune therapy, and there are also people with mucosal melanoma who, through a genetic mutation analysis, such as the MSK impact panel, can have actionable mutations found. And so those principles really carry forward to the treatment of other cancers. Lung cancer, for example, was one of the first to be recognized of the common malignancies that responds to the same sort of immune therapies that melanoma does, probably because in some patients with lung cancer, their tumors are very mutated because of exposure to tobacco smoke. So that's one example of how lessons that we learn studying melanoma can have impact on the greater population of people diagnosed with cancer. And I think it's just another opportunity for us to communicate with colleagues to develop better treatments for all of our patients.
Thank you very much, Jedd. I think this has been a really enlightening conversation. It is 11, so I wanted just to share one final thought and then transition this to Sam to close for us. It's been our pleasure on behalf of our whole melanoma program at Sloan Kettering to discuss a lot of these important topics with you. It is 11, so we'll close the formal program, but we will try to, as much as the panelists are available, answer some questions individually by typing back some responses. We can't get into details about individual cases, but we'll try to answer some questions in general ways. And want to thank AIM again. I think in remembrance of Val Guild and her real vision for what AIM can be. I think this is quite a privilege. I know she would be very pleased to hear how we're moving the field forward and how her daughter Sam is carrying this for all of us. So thank you to AIM. And it's our pleasure as a melanoma group at Sloan Kettering to have participated in this with you today. And we thank you all for your attention.
So I want to thank MSK. I really appreciate it. I know it's been a very, very difficult few weeks in your area of the country, like everyone else's, but particularly in New York. And so I really appreciate it. When I first came to you guys and said, hey, do you really still want to move forward with this? Leave it to a New Yorker to say, well, of course we're going to move forward. Why would we not? And that's the exact response that I got. And being a former New Yorker myself, I was not terribly shocked either. So thank you so much. I want to thank everybody who attended the event. We had lots of great questions. I thank the panel for agreeing to type some answers back. But if you did ask a question and did not get a response and you have to go about your day, we understand. I want to remind you that AIM has a free service where you can reach out to our physician assistant and email or call and get your question answered. If you go to our homepage, which is aimatmelanoma.org, you can find her there and a link to her, and she is more than happy to answer those questions. Also, once you end this, you'll be receiving a survey. I want to encourage you to complete the survey. We're going to continue with these events throughout the summer and fall, all virtual, and we want to make sure that your feedback is included in those events. Again, thank you everybody for joining, and thank you for the kind words about my mother. I know she enjoyed working with all of you and serving the patient community. Thanks. It looks like everybody has stayed on, quite a few people. So if the panel's going to answer questions via type, we'll do that. Thanks. There's a question I see from Simon. How will we get answers? The panel, I think if they can, they're trying to answer some of the questions by typing it in. I have included in the chat feature the link to Melissa, who is our expert, our melanoma expert here at AIM. And you can go to that link if you have a question and email her as well.
Sam, is there a way that certain questions could be directed to certain panelists from the
Not that
Q&A?
So if you type in the answer, it will only go straight to the person that asked it, and no one else will be able to see it.
Okay. I see there's a question for Dr. Hay at the very bottom. Jennifer, do you see that one? Would you be able to?
Yes, I was in the midst of typing. Should I?
Okay, good.
Yeah, I think that would be the best way, right? Just to.
It seems like it. Yeah, I
Yeah.
think so. And then I think that, yeah, I just want to make sure we're not working on some of the same questions, I guess. That one looks like that was directed at you directly.
Yeah,
So,
I'll go ahead and answer.
okay.
I'm going to respond to the question about imiquimod for lentigo maligna.
I'm
Okay,
working on the
Chris.
sugar.
Which one, Allison?
There's a question about eating sugar. So
Okay,
I'm
good.
working on the answer to that one.
Okay. And I don't know, Jedd, if you would be able to do the patients with stage 4 melanoma candidates for immune therapy if they have autoimmune diseases?
I'm doing it now.
Oh, perfect. Okay, great. I was going to start on that, so I want to make sure we're not duplicating efforts here. And again, I'm sorry, we won't be able to answer specific questions about individual patient detailed care plans. I think that those are best discussed with your doctors, or that we would be glad to provide formal second opinions from Sloan Kettering. We want to make sure we would be able to offer an opinion based upon a complete review of everything, review of the images, pathology, and all of the details, so we don't misspeak with saying something too quickly without fully comprehending the whole situation. So if you wish to have kind of a formal opinion, feel free to work through our website. If you go to mskcc.org, and there's ways to say new patient, you can click on that. There's a way you can request an appointment by phone or by sending a message electronically, and then they'll collect all of your detailed health records, and then we could provide some virtual second opinions even, or of course we would be glad to see patients in person. We do appreciate there are a lot of good questions about individual cases, but since we want to make sure we have all the records to offer a very detailed opinion, I would defer those questions to those more formal experiences and interactions. I think that will be better for you as patients too, so that you can have a back and forth conversation about your specific situation.
I have to say, we've never had this happen before where we have so many questions. Everybody has to keep typing.
Yeah, I wasn't sure how to traffic all the questions here with all of our.
Neither was I. I appreciate you guys staying on. We're no longer on Facebook.
I did the ipilimumab and breast cancer question just now.
You can just you dismiss them when you've answered them. That helps.
Oh, okay.
And there is still several attendees. So if there's one question, like the sugar one, that everybody might want to hear, you might want to be able to talk about it.
Sure, I'm happy to answer that in a general form. I just sent to whoever sent in that question, I just sent you an answer back as well. But the question of does sugar feed cancer and should I avoid all sugar is a really common one that we get asked. It's important to know that sugar feeds every cell in your body. And everything that you eat and all of your fuel comes to your cells as a source of sugar. So while excess sugar is probably never good for anyone, it is important to know that your immune system that we are capitalizing on for immunotherapy and your other healthy cells also need sugar. There have been numerous studies to date that have really suggested that eating sugar does not change the outcome for melanoma or other cancers. And I think it is important to eat a wide variety of foods and a balanced diet, but avoiding sugar in and of itself is not the solution here. I will give a plug. There is a clinical trial that is going on at MD Anderson that is specializing in diet in melanoma, that is being run by one of my friends and colleagues, Dr. Jennifer McQuaid. And hopefully in the coming years, we will have some more data from that on specific components of diet that may be really important.
I wanted to answer a live question about how stage 4 mutation type affects treatment beyond BRAF mutations, specifically around NRAS mutant melanoma, which is the second most common type of melanoma. So for NRAS melanoma that's stage 4, that is treated with immune therapy initially, either a single agent PD-1 drug like pembrolizumab or nivolumab, or the combination of nivolumab plus ipilimumab or a clinical trial. After immune therapy for patients with NRAS melanoma, there are some clinical trials that are testing other types of treatment in that kind of context. And most of those are small molecule pills that can block the different pathways that are activated by an NRAS mutation. So if you do have NRAS mutant melanoma or really non-BRAF mutated melanoma and you have had immune therapy and you have stage 4 melanoma, that would be a situation where you should really be asking about different clinical trials, either testing new immune therapy approaches or other types of small molecule approaches to target the NRAS mutation pathway. So I would encourage that for clinical trial space.
I just answered a question about, it sounds like someone had a question about PET scans and being able to see, an abnormality from, melanoma on a PET scan. And the basic answer is that, we have a lot of imaging tests which can be used to check and, see if the melanoma, is there. But none of these tests are perfect. And, we use different tests in different situations. But as Dr. Bartlett mentioned, sometimes just by physical examination, of the patient by the doctor, will melanoma be found, and it's not obvious on a scan. So that's why we use different techniques, both imaging as well as physical examination and other things, to kind of help identify whether melanoma is there, is it coming back, and so on and so forth. One of the newest evolutions in technology is trying to use blood tests to see if those can actually find melanoma. And there's a lot of work that's ongoing at our center looking at that right now. So unfortunately, none of these tests are perfect, but that's why we kind of use different combinations of them, as Dr. Bartlett mentioned.
And I got a question too about, which I think is good for a quick live discussion, about different dermatologic care. I think Ned, I guess this will, I know you're not a dermatologist, but Ned and Jennifer maybe to comment on kind of, I've been diagnosed with melanoma, I've had surgical resection of the melanoma, but maybe I have red hair or freckles, light skin tone, blue eyes. What kind of services should we be thinking about? What should I be doing from a preventative standpoint about preventing new primary melanomas from coming? How should I be thinking about this from an emotional standpoint? So any comments, Ned, and then Jennifer, if you have a minute.
Yeah, I think actually that's an important question, and especially for patients with early melanoma that's low risk, the risk of a new primary is probably higher than the risk of the first melanoma ever coming back. Generally, I would tell patients that once you've had one melanoma, there's about a 10% chance over your lifetime that you're going to develop another. And it's because all those risk factors that were present to develop the first one can contribute to you developing the next one. And so regardless of what your melanoma follow-up is for the melanoma that you're presenting with now, dermatologic screening to catch future melanomas at an early stage is an important component of the care, for sure.
Yeah, and I would just add to that, in addition to seeing your dermatologist can teach you how to do a skin self-examination, which is something that, many patients decide to do every month or every 2 months, just to scan their entire bodies and have a family member help them with difficult to see areas, so that they can kind of really be on top of any changes in their skin. Often dermatologists in these higher risk patients are using photography, whole body photography, to really document, you know, how your body looks, you know, at one point, so that then they can, you know, better see if there are changes over time, and that can cut down on biopsies if things have not changed. But the, you know, just two other pieces of that is that, you know, if you do have that phenotype of, you know, red hair and lighter skin, it's probably pretty important to, you know, be on top of sun protection and being careful around, in the sun during the, you know, the times where UVB is the highest, which is, you know, 10 a.m. to 3 p.m. In the summer. You know, there are various ways to get around that, to exercise or be on the beach, you know, early in the day, late in the day, that, you know, to kind of strategize ahead about how you can, you know, still be outside, still maintain your quality of life and exercise, while just not exposing yourself to the, you know, most strong sun rays. And then the other piece is just to talk to your family, because often when people do have the red hair phenotype, it is a kind of a family affair. And so you may have kids, you may have grandkids who have that same phenotype, and you wanna talk to them about sun protection and self-screening at a young age, and really making it, you know, a family project to reduce your risk.
Great, thank you, Jennifer. So with that, we are 15 minutes over. We appreciate the real enthusiasm with all the questions, and we're hoping that an additional 15 minutes really helped a lot of burning questions. But I will call your attention to the Zoom webinar chat, where Samantha sent out a link for AIM's physician assistant that can additionally help answer questions that may not have gotten a chance to answer during this session, or that might come to mind after we're done. With that, I don't know, Sam, if you had any other final thoughts, but with this, I just again thank everybody for participating, the panelists, the patients, and AIM.
No, I think, again, just want to remind people, Melissa, who's our physician assistant, there's also a phone number, a toll-free number, if that would be easier for you. As again, thank you, everybody, and thank you, everybody, for sticking around. I appreciate it. I know it's getting a little bit late on Saturday morning. So thank you again, and have a good weekend, and be safe.